Good morning, friends. As per my promise, uh, I am coming with the lung cancer topic on our YouTube channel as a part 1, lung cancer. The current scenario in India regarding the lung cancer, it has gone on the top of the cancers among the cancer. Like in the lung cancer, as per the current ICMR 2021 data, the lung cancer is the first and the most common cancer in Indian scenario. The second is breast cancer, third is the cervical cancer, and almost third rated is a head and neck cancer, and the fourth is the cervical cancer, fifth is the hematological cancer. This is the current scenario of ICMR data, which is more comprehensive after the clubbing of the population-based cancer registries with the hospital-based cancer registries running in the tertiary cancer centers, tertiary centers like medical colleges and the various hospitals. So the lung cancer is histologically divided into the differentiated and undifferentiated. The differentiated consists of squamous cell carcinoma, adenocarcinoma. Out of that, the squamous cell carcinoma is 50%, adenocarcinoma 20%. Undifferentiated comprises of a small cell carcinoma or large cell carcinoma. If you see in the totality, the 85% carcinomas are basically non-small cell carcinoma, and small cell carcinoma merely consists of 15% cancer. The WHO has classified the non-small cell lung cancer into the squamous cell carcinoma. Its variety is epidermoid, spindle, mesothelioma, and adenocarcinoma have a different varieties like acinar type, papillary type, and the bronchoalveolar carcinoma, depending upon the type of origin. The third is the large cell carcinoma, and the small cell carcinoma is divided into oat cell, intermediate, and a mixed variety. Out of all carcinoma, the small cell carcinoma is more dangerous, more lethal, and almost a systemic disease. So the squamous cell variety of a lung cancer arises mostly from proximal bronchi because of the ability of a squamous cells to exfoliative nature. This tumor can be detected by the cytological examination, by bronchoalveolar lavage or sputum examination, cytology examination. The squamous cell carcinoma having a best survival rate among all cancer, and it has a strongly associated with the cigarette smoking, and 50% of all lung carcinoma are diagnosed as squamous cell carcinoma. I told you that squamous cell carcinoma basically arise from the proximal bronchi. So you see here in this typical X-ray, the left lung having a proximal bronchial mass lesion, and this mass is there in the MEIASTINAL as well. So you can see that it's pushing the trachea more towards the right side. So two findings in the radiological findings you can observe here. So all in all, that I want to convey to you all that squamous cell carcinoma, usually you see the proximal bronchial lesion. The similar CT finding you see here on the posterior medial aspect of right lung having a mass lesion, and then you can easily, by seeing the CT scan, you can say it's lies at the level of a carina, because you can see that a trachea is bifurcated into the right and left main bronchus, and then a heterogeneously enhancing irregular lesion present on the posterior medial side of a right lung, and an proximal bronchial lesion, we can say it's a squamous cell carcinoma radiologically. So far as the adenocarcinoma of a lung is consist of 20% of all lung cancers, because these tumors arise mostly from peripheral surface epithelial mucoid glands or a bronchial mucoid gland. The typically X-ray shows as a peripheral mass lesion, and contrary to the squamous cell carcinoma. And a variety of adenocarcinoma is also called a bronchoalveolar carcinoma, which arises from the type 2 pneumocytes which secrete surfactant, which we know the clinical prevalence and the surfactant. Metastasis in adenocarcinoma may do occur in liver, bone, brain, adrenal gland. You see this radiological X-ray picture, you see the peripheral bronchial lesion. Because of the peripheral lung mass lesion on the right lung here, you can observe there is no disturbance in the mediastinum. The trachea is centrally placed, no pressure effect on the trachea, the head, and that's a mass lesion. So, adenocarcinoma may also secretes growth hormone, corticotropin, calcitonin, follicular stimulating hormone, luteinizing hormones, and also present as a picture with a hypertrophic osteoarthropathy, more commonly occur in adenocarcinoma variety of a lung cancer. And adenocarcinoma has a worst stage match prognosis compared to the squamous cell carcinoma, because of its pattern of distant metastasis. The metastasis in adenocarcinoma may occur in the liver, bone, brain, adrenal, as I told you, and adenocarcinoma has a worst stage match prognosis compared to the squamous cell carcinoma. Now the large cell carcinoma, it constitutes of 15% of all lung cancer. It has two kinds. One, a giant cell variety, a very aggressive type, and a B cell, clear cell type is also aggressive type. So, I mean, I just want to clarify you the clear cell variety of, among all cancers, a clear cell variety that has a clear cytoplasm, that's why it is called clear cell type. It has a very, very aggressive properties. In the 50% cases of large cell carcinoma, patient develop brain metastasis. However, its metastasis pattern is similar to the adenocarcinoma. So the large cell carcinoma also arises from the do have a peripheral origin. I mean the peripheral, an X-ray you see the peripheral mass lesion. Here in this picture you can see the posterior medial aspect of a lung. On the left side you have a peripheral irregular enhancing mass lesion and almost approaching towards the right principal bronchus, left principal bronchus, and it almost at the level of a carina. You can see here the aorta picture is clearly defined. Now I'll be telling you the small cell carcinoma. The all variety among 85% is non-small cell and then 15% is small cell variety. This 15% of lung cancer small cell variety, the radiological picture is similar to the squamous cell carcinoma since both present as a central lesion. It's a highly malignant tumor involving very early hilar and mediastinal lymph node. Metastases do occur by lymphatic and a vascular channel both. At the time of a diagnosis, most of these small cell lung carcinoma patients do have a distant metastasis. So you see here in the picture, the small cell carcinoma of the right lung is a proximal bronchial lesion involving part of a opposite lung as well, and it's a highly aggressive variety. Here you see the small cell carcinoma CT picture, irregular enhancing lesion on the posterior medial aspect of the right lung, almost infiltrating the right principal bronchus, and a very multiple mediastinal lymph nodes studied here. So spread of a lung cancer, the metastasis pattern and the pattern of spread of a lung cancer is by three means. One is the direct spread, second is a lymphatic spread, third is a hematogenous spread. The direct spread do occur to the adjacent lung parenchyma, contiguous spread to the pleura, pulmonary vessels, aorta, chest wall, and an mediastinum involves the by pressure effect or involvement of recurrent laryngeal nerve, phrenic nerve, mostly because of a large mediastinal lymph node causing a pressure effect on these nerves. The lymphatic spreads mainly involve the paratracheal hilar group of lymph node involved first, and that the mediastinal lymph node is involved. However, direct mediastinal lymph node involvement do occur without involvement of the hilar lymph node, that is called skip metastasis, which is having a 30% present in the 30% cases of lung cancer, skip metastasis. So that without involving the hilar, the mediastinal lymph node might be involved. The hematogenous spread most commonly through the pulmonary vein to the opposite lung, that's upstage the lung cancer, and an organ like brain, liver, bone, adrenal gland metastasis do occur. A very simplified staging system. One must know the stage 1, the growth limited to lung parenchyma. Stage 2, hilar group of lymph node involved. Stage 3A, mediastinal lymph node involved. Stage 3B, chest wall involved. Stage 4, distant metastasis in different organs or opposite lung involved. Pleural effusion is present, bring the patient to the stage 4. But however, AJCC 8th classification is being given for the lung cancer staging. You guys must go through that. It's a very simple staging system, and usually more precise and more clarified. So, and for clinical purpose, by seeing the ultrasound X-ray, by seeing the X-ray and CT scan, you can go for this kind of a lung cancer simplified staging immediately, and you can write on the file then the stage 3A, stage 3B. The symptoms of a lung cancer, the primary symptoms, pulmonary symptoms are in a very high cases of 80% case, almost 75 to 80% dry cough, merely 5% to 6% cases hemoptysis, chest pain is a more common, dyspnea, wheezing, stridor, or present. The extrapulmonary symptoms like pressure effect on the recurrent laryngeal nerve lead to the paralysis of vocal cord, lead to the hoarseness of voice. And the superior vena cava syndrome, you might observe pain down the arm due to brachial plexus involvement, Horner syndromes due to involvement of a superior sympathetic ganglion, ptosis and hydrosis are the symptoms there you found. Dysphagia due to paraosophageal nerve involvement. Phrenic nerve involvement lead to the diaphragmatic paralysis. So that side of diaphragm, you can see after the paralysis is moved upwards. On the radiological picture you can predict out. The extrapulmonary metastasis symptoms like brain lead to the seizures, hemiplegia, headache, vomiting, confusion. These are depending upon the brain metastasis. One of the paraneoplastic syndrome do occur in the lung cancer that are called extrapulmonary non-metastatic symptoms, like in a Cushing syndrome due to excess of corticotropin secretion. Excessive area secretion lead to hyponatremia, hypokalemia, and hypercalcemia. Clubbing, you can find acanthosis nigrans, migratory thrombophlebitis, Straussi's sign is usually found, and these symptoms are more geared towards the adenocarcinoma variety, which I've already told you regarding the symptoms of adenocarcinoma. So, what should be our approach for the lung cancer? Investigation, the chest X-ray first to see the hilar lymph node, mediastinal lymph node by the lateral chest X-ray view, lung mass, evidence of bronchial obstruction like collapse, consolidation, pleural effusion. These findings you can easily predict out by the chest X-ray. Elevation of a diaphragm of that side suggestive of a phrenic nerve palsy. It is said that the lung cancer detected on X-ray, once detected in X-ray, it has already crossed 3/4 of its natural history. Henceforth, the CE-CT thorax required to detect the early lesion. So, for the investigation of a choice as of now is a CT thorax rather than the X-ray for lung cancer, because in the lung cancer, you just it's a tip of iceberg. What you see in the CT scan, actually in the detail lung, lymph node, and the involvement and the size of a tumor. The radiological picture of a different type of a lung cancer would be different, like a squamous cell carcinoma. X-ray more commonly present with the collapse, consolidation, central and proximal bronchial lesion. Why it is happened? Because of a central and proximal bronchial lesion which cause the distant part collapse or consolidation, which is more commonly seen in squamous cell carcinoma. Adenocarcinoma X-ray is more often present in peripheral mass lesion, thus obstructive bronchial lesion is very less common picture in adenocarcinoma or large cell carcinoma. The small cell carcinoma in 80% cases present with a hilar abnormality in proximal central lesion. Henceforth, like a squamous cell carcinoma, X-ray picture is like this, but the lymph node involvement is very high percentage, mediastinal and hilar lymph node in small cell carcinoma. The other examination, like sputum cytology, is positive in 60% case of squamous cell carcinoma due to exfoliative nature of squamous cells, as I already discussed with you. Squamous cell carcinoma involving the proximal bronchial lesion thus more likely to come in a sputum. Because of that, the sputum cytology is more positive in squamous cell carcinoma. But in adenocarcinoma, the chances of a sputum positivity very remote, because the lung lesion is as there in a peripheral lesion and not communicating to the bronchus. So bronchoscopy examination is one of a very vital examination. the fibro-optic flexible bronchoscope with the help of direct visualization of a tumor, as well as the biopsy can be taken from the central lesion, pickups early with accuracy of 90%. So the first central lesion, the biopsy in a bronchoscopic biopsy have a high yield result 90%, but in peripheral the accuracy dropped down to the 45%, half of that. While in the central lesion, the bronchoscope can easily see and pick up the lesion and taken a biopsy, but the reaching the bronchoscopes up to the peripheral lung, the probability is very less, so that this data comes down to 45%. See here, the lady is doing a typical bronchoscopic examination to a male, and then the flexible bronchoscope is through the by endotracheal route, and a monitor displays the lesion, and once you find the lesion, you can, by doing the bronchoscope, a biopsy taken from that lesion. So this is a way a diagnostic picture of doing a bronchoscopic examination. What you get in a bronchoscopic examination is not what you actually understand. We can get first the length of a normal bronchus proximal to the tumor. If a length is as long as that, which helps in the planning for lobectomy, surgery purpose. Bronchoscopy can see the status of a carina because of a widening of the bronchus because of a pressure effect from at the level of a carina by lymph node because of subcarinal lymphadenopathy. So you can understand that by seeing the widening of a carina. Vocal cord palsy, while taking out this thing, you can bronchoscope, you see the vocal cord palsy. So the recurrent laryngeal nerve palsy, we can get an information by bronchoscopy, which indicates the tumor whether it is operable or non-operable. Recurrent laryngeal nerve palsy almost make the tumor inoperable. The FNAC investigation is ideal when the tumor is located in the peripheral lung lesion and the sputum cytology negative. The FNAC can be done with the help of CT scan guided FNAC. CT, by putting the patient on the CT table, you find out the depth and an angle by which you introduce the needle, so you can go for a cold needle biopsy on the CT biopsy of a lung. CT thorax done to see the primary tumor along with the HILAR MEIASTINAL lymphadenopathy also give idea about tumor infiltration to the major vessels. CT helps to see the opposite lung parenchyma as well, and CT guided FNAC or conidal biopsy can be done to confirm the type of lung cancer. You see here the CT guided FNAC on a monitor on the console. You see the needle. For initially we take the CT and see the primary tumor and depth and the angle, and by knowing by the help of CT scan, you can go for conidal biopsy or FNAC needle. We can put on the chest wall and then get a material for investigation. You see here a picture of X-ray having a lung mass lesion. Lung mass lesion is almost, it appears like it is arising from a peripheral side, but it is actually central lesion, because you can see in CT scan clear-cut area between the chest wall on the right side and the tumor mass have a space in between the normal lung. So regarding the treatment of a lung cancer, all three modalities of oncology like radiotherapy, chemotherapy, surgery used for the lung cancer management. And now in the new era of molecular oncology, targeted therapy is now extensively used for lung cancer. The treatment of non-small cell lung cancer, stage 1 and stage 2 required surgery in form of lumpectomy, but the lumpectomy is the choice. Lumpectomy or segmentomy is more preferred because the complication rate is lower down, quite lower down in compared to lumpectomy or lumpectomy. But prior to the surgery, the following test is required to be done. First, a pulmonary function test like FEV1 should be more than 1.2 liter or forced expiratory volume 1 about 4x function FVC ratio. If less than 75, it indicates the obstructive lung disease and patient not suitable for surgery. The breath holding test should be more than 20 seconds. ABG, arterial blood gas level, peripheral pulse oximetry, O2 saturation must be more than 90%. ECG for cardiac function test along ejection fraction must be more than 60%. So these parameters is help for a CTVS surgeon whether to operate or not the patient. You see, this segmentomy complication rate is 10% and mortality is only 1.3%, and a lumpectomy is slightly higher mortality rate 2.9%, and pneumectomy the mortality goes up to 6.2%. So why the most of the lung cancer patient is not deemed suitable for a surgery? Because they present in the late stage, and then the symptoms develop in the late stage, the radiological pictures develop in the late stage, pictures, unless you go for a CT very early. So what are these contraindications? The recurrent laryngeal nerve palsy, phrenic nerve palsy, mediastinal lymphadenopathy, opposite lung involvement, patient is superior vena cava syndrome, growth involving trachea, esophagus, chest wall erosion, distant metastasis, growth present in the principal bronchus, patient having a poor lung function or cardiac function, patient having a pleural effusion, unilateral or bilateral. So you see the 11 points of a contraindication almost makes a very, very remote possibility of a lung cancer to be operated upon. So that is almost put the radiation oncologist or clinical oncologist to put their arms, that is radiotherapy and a chemotherapy for locally advanced non-small cell lung cancer. The brain metastasis usually occur in 30% cases of non-small cell lung cancer, and also the lung mets are usually single and solitary. So for brain mets, we can use whole brain radiotherapy that can increase the survival more than 6 months and 20 gray 5 fraction or 30 gray 10 fraction. However, due to single solitary region, we can consider the X knife or gamma knife. So it's very interesting that the lung cancer is usually having a solitary brain mets, and then the breast cancer is having a multiple enhancing lesion. So the gamma knife is more suitable. X knife or gamma knife treatment is more suitable. This kind of and more in the use in the lung cancer. Adrenal metastasis occur in 30% lung cancer patients. So traditional radiotherapy dose is 60 gray 30 fraction is used, and a 15 millimeter margin given in the craniocaudal direction and 6 millimeter margin taken for transverse direction in earlier era. But due to advancement in the radiation oncology, the things are getting changed very, very on the 360 degree almost. Because we more practice toward the SBRT, though the pool of a data is not with us, but because of a radiobiological, if a biological effect as well as the high-end machines like a cone beam inbuilt linear accelerator, getting a very fine uniform slices. We go for SBRT, but traditional dose is 60 grain 35% is still used in the centers. And a brachytherapy can be used alone with a combination of external beam RT. A brachytherapy indication when the hilar lymph nodes involved or adherent to major vessels, tumor, attachment of tumor to mediastinal structure. So by HDR we give 6 to 7 gray per fraction to total dose of 15 to 20 gray. See here the linear accelerator, the tumor is getting a radiotherapy, the conventional lung cancer radiotherapy, courtesy RF circuit system lab at Texas Technical University. So you see here that we go for a radiotherapy. Really the portal used, and by putting a lead wires and I get a chest X-ray done and the marking done, and then you go on the 2D planning. But more we are focused through the 3D planning, conformal radiotherapy in the lung cancer after the advancement and the development of multiple high energy linear accelerator along with the multi-leaf collimeters. So the most advanced system you see here, the continuous imaging by optical surface guidance system, and then you see the linear accelerator, the patient have a multiple beams used to get a PTV dose 90%, 95% coverage and protecting the critical organs. So continuous optical surface guidance system giving a image and your image correction, and then image correction, and then again finalization of tumor localization on the DAR beams eye view. We implement this kind of radiotherapy. So you see here then the CT based radiotherapy planning, beams, weightage of a beams is all decided on a 3D treatment planning system to give a conformal radiotherapy to the lung cancer patients. Brachytherapy is also being practiced in lung cancer for proximal bronchial lesions, small cell carcinoma or non-small cell lung carcinoma with the help of bronchoscope. The catheter introduced to the primary site and the dose is delivered. The role of a chemotherapy for non-small cell lung cancer like cisplatin etoposide is fitted both in a non-small and a small cell carcinoma, but there are multiple very advanced cancer treatment medical oncology in lung cancer. So those who are interested, they can go with that medical oncology lecture of a lung cancer. But go for this thing. The recurrence of a non-small lung cancer within lung is 30 to 50% cases of do occurs, and distant metastasis occur 30 to 45%. So the non-small cell carcinoma more geared towards the within lung metastasis, but adenocarcinoma, large cell carcinoma do have a tendency to recur with disseminated disease contrary to typical squamous cell carcinoma. So little bit about the small cell carcinoma. We already told that it comprises 15% of all lung cancer, and it's a very much chemo-responsive tumor. Almost 50 to 60% tumors show complete response with the chemotherapy. It is like a squamous cell. It is also strongly associated with the smoking. And if left untreated, the median survival of a small cell lung carcinoma nearly only 3 to 6 months. Typical TNM staging is not used in small cell carcinoma since the tumor usually do not undergo surgical resection. The small cell lung carcinoma is spread very fast to the regional lymph node as well as distant metastasis. The small cell lung carcinoma stay of treatment is chemotherapy. Mainstay of treatment is chemotherapy, as well as prophylactic cranial irradiation, whole brain irradiation. Reduce the chances of brain metastasis from 25% to 5%. And then primary lung radiotherapy disease for a limited disease, radiotherapy dose given 45 to 50 gray to the primary tumor. So thank you very much. In this next subsequent lecture, I'll be dealing with the lung cancer part 2. That would be more geared towards the chemotherapy regime and what are the molecular markers in the lung cancer. So according to that, the targeted therapies. Thank you, gentlemen.